Welcome to Duke Spine Institute. We have a live stream. Our patient has 25 years of back pain. He comes from Virginia. He found us on the internet. We did a MRI review with him and figured out that his pain is coming from 2 discs at the bottom of his spine. He's had microdiscectomy, laminectomy. He's already had surgery. Did not work. We always tell people stay away from these microdiscectomy, laminectomy because they don't work. They just create instability. The doctor that does the surgery is taking away bones and ligaments out of your spine. It's weakening your spine and your body. Plus, they very painful types of surgery. There's a lot of scar tissue that's created. But we're doing the Duke laser disc repair today. And basically, we're going after the source of his back pain. The source is 2 things. He has the L4-5, L5-S1 discs that are injured. He also has facet joint arthritis. Shot? We're going to do the facet joint second. We're going to do the disc first. So we're going to do a separate live stream for the facet joints. If you have questions, feel free to ask them. You can see the needle is heading to the L4-5 disc on the left. Shot? Now, on the right side, we're going to do the L5-S1 disc. Shot? Go ahead and shut down the window a little bit. If you have questions, feel free to ask. I'm happy to answer them for you. You can actually see the herniated disc. Take another shot because it was better before you did that one. Well, it's hard to see now. All right, it was easier to see before we windowed down, but that's fine. You can see the herniated disc on the x-ray. The reason why you can see a herniated disc on the x-ray shot is because calcification of the disc. What does that mean? When you have a tear in the back of the disc and a herniation through the tear of the nuclear material, over time, with lots of chronic inflammation, you get a calcium deposit in that disc material. And you can see that on the actual x-ray. And that's what we were seeing. We're seeing calcium deposit from chronic inflammation. Okay, we're heading to the L5-S1 on the patient's right. Everyone agrees? Sean? All right, I have to get down to 5-1. Not an easy task in some patients. 5-1 is the hardest disc to get to in the lumbar spine. It is extremely difficult because of anatomy, the patient's anatomy. Sean? How is he doing, Dr. B?
How are you doing, my friend?
AP?
He said he's doing good.
All right, lay still. You're doing great. We're gonna have you asleep in a moment. Yeah, it looks good. You can see the needle at L4-5 is in perfect position. L5-S1, we're almost there. Are you having any pain? What do you say?
You said, I'm sorry, can you hear you? Say one time? Not right at the moment.
All right, good to hear. Sean, let me know if you have any pain. Feeling anything?
Are you feeling any pain in your back? Any pain down your leg? No pain.
Perfect. AP? So we're looking good at 5-1. We're going to just check a front-back view on the x-ray. That looks perfect. Show us where the nerve root is, just for the people watching. We're going to show you where the nerve root is. So first find the pedicle. Find the pedicle of L5. Yep. Just show them the whole pedicle. See the dark line like a circle? That's a pedicle. Now the nerve exits just underneath the pedicle, right where the arrow is. But show them the course of the nerve, starting medial. Go medial, medial, up, up, a little bit, right there. So if you follow the arrow down and around the bottom of the pedicle, that's where the L5 nerve root goes. So we are just below it, okay? Now the S1 nerve root, it takes a different course. Go back to where you were. Medial to the pedicle, medial to the pedicle. Yes, now go down to the next level. Yes, and wrap around the S1 pedicle there. You see it? Yep, that's the S1 pedicle, the S1 nerve root. So we're working just lateral to the what's called the traversing nerve root and just below the exiting nerve root. That's where we are. That's how this surgery is done. It's called transforaminal. All right, let's show the audience that there's more than one cause of back pain. There's about 30 things that cause chronic back pain. And let's show the audience those 30 things. The disc is the most important. I'm Dr. R. Duke-Magin with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke-Magin. Thanks for joining us. I think we're good, right? Welcome back. So what we've done so far while you guys were watching our video, number one, the video, the most important thing to understand is that there's more than one cause of back pain. There are 5 discs, there are 10 facets, there's 2 SI joints, 2 piriformis muscles, there's bones that can be fractured. But the most common cause of chronic back pain is the disc injuries, called disc injuries. I call them disc injuries because everybody uses different words. Disc herniation, disc bulge, disc rupture, disc slip disc, protruding disc, extruded disc. So I can't keep up with all the different terminologies, but they're all the same basically. It's an injury to the disc. And there's a tear in the back of the disc called the annular tear. And the herniation goes through the annular tear, gets stuck in it, causes inflammation. That's what causes back pain. So it's inflammation in the back of the disc. Now, while you guys were watching the video, we tested the 2 discs we're fixing, L4-5, L5-S1. L4-5, 10 out of 10 pain, concordant. That means that's his typical pain he gets every day. The bottom disc, L5-S1, was 20 over 10. It was so painful, he said it's 20 out of 10. And I said, is that your typical pain? He said, yes. So it's concordant. So we know that we're going to fix both discs now with laser, and that's going to get rid of that disc pain. He still has facet pain. We're going to do that next. After the disc surgery, we're going to stop the stream, restream for discs for facet surgery. All right, I know we have some questions. We'll get started on repairing the first disc. We'll take the questions, and then we'll go to our next video.
Of course, this first question is coming from Faisal on Facebook.
Welcome, Faisal.
Asking, eye doctor,
Hi.
why do disc herniations get missed by surgeons or by scans? Or also, can I ask you the difference between a soft or hard disc? Thank you.
Yeah, sure. Great question, Faisal. Your question is extremely insightful. It shows your understanding of the problems. So why do surgeons miss this? Because surgeons don't know that discs herniation, damaged disc can be painful. They're not taught that. Nobody knows that. I figured that out years ago, about 20 years ago now. And I've been trying to spread the word. I think maybe eventually more doctors will start to understand that the disc is the source of pain. But I've tried publishing my results. And for the most part, neurosurgeons just don't want to deal with pain. They don't like pain because they don't understand it. So they leave pain to the pain management doctors, and the pain management doctors have no way to fix disc pain unless they do surgery, which they're not supposed to because they're not surgeons. They're pain management doctors. But that doesn't stop a lot of pain management doctors from doing things they're not supposed to do in the interest of profits. Long story short, 99% of doctors have no clue where back pain comes from. So those 30 causes of back pain I just showed you, it comes from our patients, from years of research and analysis of thousands of patients. Something is not right. I'm not getting enough energy here. Take that. Grabber. You think the mirror is out of alignment?
No. That will be loud. Very loud.
All right. So, number one, doctors don't know that the disc is the cause of pain. Number two, why are they missed on the MRI? Because radiologists don't understand the importance of a herniated disc or bulging disc, so they usually don't mention it. But a lot of them are good at mentioning bulging discs nowadays. So they're getting better at identifying bulging discs or problems with this. But doctors are not putting 2 and 2 together. They're not understanding that the disc damage is what's causing the pain. And there's reasons for that. Most notably, if you go and you fix a disc, they usually only fix one, the worst looking one, which they'll leave 2 more that are painful, so the patient still has pain. So they feel like the surgery didn't work. And number 2, there's other causes of pain, right? Besides, can we turn the scope off? You got to learn how to do that stuff. We're changing our laser fiber right now. Take your time. Let me know when you're connected. And I think the last question, soft disk versus hard disk.
Correct.
Hard just means more calcification. Soft disk is less calcification. All right, next question.
Next question coming from Faisal once more on Facebook, asking, Doctor, if you have neck pain when you touch your joints next to the skin, can it still come from a disc, not the
Are you
facet
ready?
joint? Thank you.
No, if you push on next to your on the side of your neck and it's tender, that's not coming from the disc. It's not possible. So what do you think it was? The fiber?
It's probably a fiber, yeah. Try holding it.
All right.
Thank you.
Yeah, that would be your facet joints. That would be muscle and facet, not disc. Disc is never tender, ever when you push on it. I mean, when you push on your spine, on your muscles, if you have tenderness, it's never the disc. The disc is deep, you can never push on it. It's impossible to push on the disc. Impossible. So, if there's no tenderness, that's a indication it's probably the disc. If there is tenderness, it's an indication probably facets or SI or piriformis. Great question. All right, any other questions?
Yes, I have a question coming from Lanu on YouTube,
Hi, Lanu.
asking, can people get MRIs at your facility?
Yes, we do have an MRI scanner here. People can get MRIs done here. Not brain MRIs, but spine and joint MRIs, yes. Next question.
At this moment, no current questions.
So then let's show the audience, why do these disc injuries hurt so bad? What is it about them that hurts?
Of course.
Disc injuries start with an annular tear. Damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A quarter-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. So you can see from our video that the reason why the disc hurts is inflammation in the back wall of the disc where the tear is, which is what we're cleaning right now. We're cleaning that tear. We're a little bit overexposed. Let's turn the light down.
Yes. Stop.
I would say one click maybe. I don't think they turned it down, but
One more.
all right, that's better. Thanks. Hector's got to learn how to do all that stuff if he doesn't know.
Hector is here? Hector is here?
Oh, he was in the OR, but
Ah, okay.
maybe he left. He may be helping with something else. 49? 49 points? That's not much. That's 50
Probably
points.
7 times good.
That's 10
Yeah,
uses.
yeah.
10 uses. That's okay, I guess, right? Is that what you're seeing typically is 10 uses?
It's around 10 to 15, 20.
Yeah.
Almost.
Yeah. Because the average is probably 5 per use, I would imagine. So if you're at 50, that's 10 uses. How much is it to repair?
1200.
$1,200. Jeez. All right, when are we getting the device for the nose?
The goal is by Thursday.
All right.
The samples.
Any questions, Henry?
Yes, sir. We have about 2 questions. Next one's coming from Lanu once more on YouTube,
Sure.
asking, this patient has a lot of herniations. Did he have had an accident?
Yeah, he has, if you look at his MRI on the bottom corner, you can see multiple herniations, but only the bottom 2 were causing symptoms. The ones higher up, he had no symptoms at all. So, did he have an accident? Everybody's had an accident. Every human being that has a disc injury has had an accident. It doesn't have to be a motor vehicle accident. It could be a fall, sports injury, football, some type of trauma to your spine. So I call that trauma to the spine an accident. But I don't know what you mean by accident. Maybe you mean motor vehicle accident. A motor vehicle accident is probably the most common reason people get disc injuries, in my opinion, my experience. Unfortunately, in America, the insurance companies tell you that you don't need any treatment, just live with it. And that's a lie, unfortunately. And people end up getting back pain from their car accident, but many times it doesn't start for several years after the accident. So they have the accident, they have some pain initially or not much, but then over time, that injured disc becomes more painful for them. And they end up having chronic back pain from that accident. But by then, it's too late to get compensated from their insurance, so they end up living with pain and not being able to fix it because they can't afford fixing it or the doctor doesn't know how to fix it. So there's the tear right there. And we're almost to the outside of the disc. So this is the last half of the outer half of the tear that we're working on. I know we have more questions, so I'll take those.
Next question coming from Charlie on YouTube,
Hi, Charlie.
asking, curious, which type of laser is used in your application? What is the energy source, and how does one learn to control it in a procedure?
Yeah, great question. So number 1, this is a holmium YAG laser, HOLMIUM YAG. It is manufactured in Israel. It is the best laser in the world for this application. There's nothing better. There are other types of lasers, but they're not very good. Not for this application, not for spine, not for endoscopic spine. How do you learn how to harness it? You have to go through training. I was trained on using the laser. And I train my staff. My staff train each other. They train new staff. So it's all about just training, proper training, like any piece of equipment. You don't have to be a certified laser technician to operate the laser. You do have to be a X-ray technician to operate the X-ray machine, but laser doesn't require a certificate or training. In America. I don't know about other countries, but in America. So, yeah. And how do you learn to use it?
Yeah, control
Just-
it. Yeah.
Just practice. Practice. Practice makes perfect, right? The practice of medicine. It's not that hard if you're a surgeon. I've used lasers when I was in training in residency. We use lasers like this for different types of procedures, like on the brain when we did endoscopic third ventriculostomy, and when we did some pediatric spine surgery for cerebral palsy, spasticity. So I learned how to use the laser about 25 years ago in neurosurgery. Different kind of laser, different kind of fiber, but if you're a good surgeon, you figure things out. It's not that hard. Good question. Any other questions?
Yes, we have a question coming from Michael on YouTube,
Hi, Michael. Welcome.
asking, are you through the back of the disc through a tear?
Yes, that's exactly what I am.
And is a herniation treated differently than a protrusion?
No. A herniation and a protrusion are all the same thing. There's no difference. A bulging disc, a protruding disc, a extruded disc, a ruptured disc, a slipped disc, a herniated disc, a bulging disc, they're all exactly the same thing. There's no difference. A bulging disc is just small, a small herniation, but all of those names are all the same thing. They're all herniated disc. That's why I said there's 10 different names for the same thing. Herniated disc is called 10 different things by different doctors, but there's absolutely no difference whatsoever. It's a tear in the back of the disc in the wall called an annular tear, which then leads to herniation of the nucleus material in the middle, which starts coming out through the tear. I apologize, the view is not great right now, but we're going to fix that in just a moment. I'm almost done with this disc. This was a humongous tear, and that's a piece of herniation there. I'm almost finished with this tear. We call this a debridement. Debridement, that's what it is. We're cleaning the tear using the laser. We're getting rid of the scar tissue, the herniation. We're getting rid of the calcification, the granulation tissue, the neovascularization, neoneurulation. All this grungy garbage here causing back pain, we're getting rid of it. So we're cleaning out. It's not an infection, but it's inflammation in the back of the disc, right here. You can actually see at 12 o'clock, we now have the epidural space where the traversing nerve root is, just outside of our tube at 12 o'clock. And at 9 o'clock, we have the exiting root. That would be the the L4 nerve root. Apologize. Great questions so far. Any more questions?
Yes, we have a question coming from Lanu, once more on YouTube,
Hi, Lanu. Sure.
saying a
You
question.
guys see that? Look at 12 o'clock. See the fat? The yellow fat? That's posterior longitudinal ligament and foraminal ligament that you're seeing just below the fat. So we're pretty much done with the tear at this point. I just have a little bit more to do. We're going to get a better scope view next at 5-1 from the other side. So I apologize once again for the kind of blurry view. Go ahead. He's coming up a little bit. Berndes. Yeah, maybe it's a more painful area. Go ahead with the question.
Coming from Lanu once more on YouTube, asking a question for Henry. The visual and audio are always very clear. Thank you. Do you or someone else do the daily maintenance? I would say 90 to 95% it is me doing the maintenance. I do have IT as a backup to help me out if any other severe issues come up. And I also have been having help from Brandon right next to me, who is our new web developer, and has been helping me out with some of the process. So, but for the most part, I try to take care of the audio and the visuals, just make sure this whole thing is just going good every single week. I treat it like it's my baby. And so it's a huge compliment to know that the audio and the visuals are very clear. And so it's knowing that I'm doing my job right. So I really appreciate that, Lano. Thank you.
Yeah. Henry takes a lot of pride in his work.
Of course. So I'm proud of it, and I just can't complain. And in that meantime, we have a lot of questions coming up from everywhere. This next one is coming from, forgive me if I mispronounced this name, Abhi on Facebook.
Hello, Abhi on Facebook. Welcome.
Asking, what steps do you take to prevent the disc from reherniation?
Yeah, great question. The most important thing, and there's really not much you have to do, the patient has to avoid heavy lifting for the first year after surgery. They cannot lift more than about 20 kilos. So restrict the lifting, number one. And number two, no bending at the waist for the first 3 months. No bending over to pick anything up from the ground. So it's basically biomechanical restriction that prevents reherniation. That's all. There's nothing else you need to do. The disc is not liquid like a lot of people think. It's solid. So it's not going to come out easily. You have to really push it out. And to do that, you have to lift heavy or bend over or do contact sports like jiu-jitsu or something like that. So I tell everybody, no contact sports the first year. All right, we are done with this disc. It was quite a bit. It was a humongous tear. As you could see, big tear. And lots of inflammation and scar tissue. By the way, for reference, the fiber, laser fiber, is 1 millimeter wide. That glass fiber is 1 millimeter wide. So that's what you're seeing. Yeah, I keep saying I'm done, and then I go back and I take a little bit more of this herniation.
We have a couple more questions.
I'll take them.
Next one coming from Charlie once more on YouTube, asking, when working in the lumbosacral area, is the access portion of endoscopy more difficult for female or male pelvis anatomy?
That's a great question. I don't think there's a difference, but I could be wrong. If anything, I would say my problems with access have only been mostly males. I don't think I've had any female access problems. And maybe there's a reason for that. Maybe it has to do with pelvic anatomy. But usually the males have very big facet joints that I cannot get to L5-S1, which happens probably 1 in 100 patients. Take this.
Yes, sir.
So it's not common. Okay, I'll take it back. It's very rare that I can't get to L5-S1. L5-S1 is the only disc that we ever see access problems with. We never see it with any other disc. All right, we just put some antibiotics. Make sure we don't get any infections. We've never had an infection. We've never had a complication with this surgery. There's never been a surgical complication with this surgery, ever. And that's in 19 years. That's how safe it is, as long as you do it properly. Now, could we have a complication? Yes. You know, we're sticking a metal pipe in somebody's spine, right? There's lots of things we could harm inadvertently, but I'm a very good surgeon. I've trained at the top neurosurgery training program in the world. When I trained, I was considered one of the top recruits, actually the top recruit the year that I applied. Coming out of medical school, I was valedictorian, #1 in my class. I was also very, very good in the neurosciences and had a lot of publications and accolades. So I was able to get to the best training program because they're very selective. They don't just take anybody. And because of that, I have a very good understanding of anatomy, and I'm a very good surgeon. I was trained by the best in the world. So I don't make mistakes very often. I'm sure I've made some, but my patients have never had complications from my mistakes. If anything, they're tiny, minor. So now, are all spine surgeons the same way? Absolutely not. There are many surgeons that are sloppy, make lots of mistakes. Same thing with neurosurgeons. So you have to be very careful. You have to be very well trained and cognizant of what's going on in the operating room. That said, the surgery can be performed very safely without any complications if you know what you're doing and you're careful. I have had to abort the L5-S1 level in a few patients, about 1 in 100. And I do that because I cannot get into the disc. But there are other surgeons that may not recognize that they can't get into the disc and may still try. And then they end up perforating the patient's bowel or blood vessel, causing a hemorrhage internally, or the patient can die. So in complications in spine surgery are, I hate to say it, but it's true. It's usually the surgeon's fault or the anesthesiologist's fault. Okay? Because the surgeon didn't recognize there's a problem. Now hold on. I want to pull the guide wire back a little bit. Okay? Now I feel, this is a huge tear, by the way. No. Let me see. Shot? I think we're good. Yeah, we're good. We're in. So Jordan, show us this tear. It's a really big tear, folks. That's where you see the dye coming out. So I went right into the tear, transforaminally. What? Okay, that's fine. So the only damage we're doing during this surgery, the only damage to the patient is the skin incision. You're making an incision in the skin that's 7 millimeters, 1/4 inch, and that's it. Everything happening underneath the skin is basically, we're just spreading the tissues. So we're not actually cutting anything. Shot? Now we're advancing the dilator. We got to keep a close eye on the dilator. Shot? Yeah. Pull the whole thing back. So this is what I'm talking about. You got to recognize when there's potentially a problem, and you got to stop before you get into a real problem. So the dilator was advancing with the tube. The tube's supposed to advance over the dilator, but that wasn't happening. The reason for that is typically because we get a little bit of soft tissue. That's good, stop. We get a little bit of soft tissue. Let me see it. No, we're going to take this out. See, this is exactly how you avoid shot complications, okay? You recognize when something isn't right, and you basically change what you're doing to to accommodate it. Now, let's pull this back a little bit. Shot. Keep going. More. We're pulling the dilator back. All right, that's good. That's probably good right there. Now let's see if we can't advance this. So I cleaned out the soft tissue. Hopefully we get a nice slide right over the dilator. That's what we're hoping for. Shot. All right, let me see. There we go. That's good. All right, good. So you see that? We just slid the dilator, slid the tube over the dilator. Shot? All right. So we're still advancing the dilator a little bit. All right. Let's see if we can pull that back a little bit. Sorry, we're dealing with a situation. It's not a bad situation, but we're keeping it from becoming a bad situation. You got it? Good job. Good job. Pull it back a little more. Mm-hmm. Yep. All right. Any questions, Henry?
Yes, we have a couple questions. Next one is
Sean?
coming from Faisal, once more on Facebook, asking, Doctor, how important is
Check it out.
your reputation? I know there's a lot of people and surgeons that don't believe that your laser treatment does not work.
Yeah. Great question, Faisal. I love it. Faisal, you got to come every single day, which I think you do anyway, because you keep bringing up really good points. So, reputation, how important is it? Great question. That was the question from Faisal. Folks, let me tell you something. There's two types of doctors. Doctors that become surgeons and doctors because they want to be part of that community of doctors and impress other doctors, and rub elbows with other doctors and be accepted among the doctors. And then there's doctors who actually want to do what's right for the patients because they went into medicine because they want to help people get over sickness and illness and become well and healthy. All right? And I'm going to tell you right now, you cannot be both. You cannot be both. Okay? In spine, if you are accepted among the other doctors, then you are doing things to patients you should not be doing. Whether you're doing fusions, laminectomies, discectomies, spinal cord stimulators. That's what all these doctors are doing in my field. And it's bad for patients. It's very bad for patients. So, do I want to be accepted by them? No. I don't care about them. I want to be doing what's right for patients. That's why I became a doctor. And if you want to do what's right for patients today, you have to be by yourself. Because not many doctors are going to do what's right for the patients. They're all wanting to do what's right for themselves. And what's right for themselves is not right for the patient. You understand? It's not right for the patient, period. Now, of course, I'm not saying 100% it's that way. There are some good doctors that want to do what's right for the patient, and they just don't know what's right for the patient. So they do what the industry tells them or what their training told them to do. But you see, I have what's called awareness. I'm aware of better treatments for patients than what's out there. Laminectomy is still being done by most spine surgeons. Horrible procedure. I do not recommend it to anybody. I wouldn't do it. It's dangerous, and it doesn't get rid of pain. It's a very bad surgery. It destabilizes the spine. So if I want to have a good reputation among my colleagues, I have to do laminectomy. I would rather have a bad reputation among my colleagues and do what's best for the patient. So you ask a great question. I think I answered it properly there in terms of expressing my feelings properly. But for years, I have been doing these surgeries. They are peer-reviewed and published. So for these doctors to say laser is not good, they're not reading the literature. They're not reading our publications. They're ignoring the truth. Okay? Now, medicine is science. Science is based on fact. Facts can be discovered and published in the literature, and we've done that with this surgery. But they're just choosing to ignore it for personal, selfish reasons that are not good for the patients. They're doing it, they're ignoring our surgery because, number one, they don't know how to do it. And the right thing for them to do is to refer all their patients to us. So instead of doing laminectomy, instead of doing fusion, instead of doing disc replacement, instead of doing pain management, instead of doing epidurals, instead of doing RFA, instead of doing injections, they should send 100% of their patients to the best, and that's us, Duke Spine. But they don't do that. Why? Because they would go out of business. And to them, being in business is more important than doing what's right for the patient. So that's the kind of people that you talk about having a good reputation with. You have a good reputation with them when you do bad things to patients. And I'm not willing to do bad things to patients to have a good reputation with them.
We have a couple more questions.
It's a great question, Faisal. Great question.
Next one's coming from Kelly on YouTube,
Sure, I'll take Kelly on YouTube.
saying they have a 3 herniations at C3, C4, and C5, and maybe C6, asking what are the restrictions after surgery and the downtime?
Well, I don't know what surgery you're having. So
I
if
believe-
you're having the laser surgery,
Yes.
there is 0 downtime with our surgery. If you're coming to Duke Spine and having your disc fixed, there is 0 downtime. You literally recover here for 1 hour after surgery, and then you go back to your hotel. You can go out to dinner, to a restaurant. You can go shopping. You can walk on the beach. You can go to the Kennedy Space Center. You can do anything you want, except you cannot drive a car or operate a machine. The first day, that's because you had anesthesia. But aside from that, you can do anything you want to do. Of course, there's going to be lifting restrictions. I don't want you lifting over 25 pounds for the first 6 weeks. And we put all of our patients in a collar or a brace for the first 6 weeks. So you can wear the brace, you can wear it driving, you can wear it to work, you can wear it to bed, you can wear it everywhere except the shower. You don't wear it in the shower. But basically, you're going to wear a brace, you're going to have a lifting restriction. And aside from that, if you have other activities like sports you like to do, you just have to ask me, when can I start doing this activity? And that's going to depend on what I see in the operation, right? But it also, there's some standard protocols that we use for every patient that has that surgery. So that's when I was talking about, I got 5 minutes on this disc, and then we're going to end the stream, and we're going to go to the facets as a second stream, okay? But basically, we do have some standard restrictions, lifting, contact sports, and then the rest you just have to ask me. It's individualized. Great question. All right, you can see we are in this tear. You can see scar tissue, granulation tissue, all this stuff causing pain, inflammation. The blue is the herniation. There's little pieces of it you can see stuck in this tear, and that's what I'm cleaning out with the laser. Once again, the laser fiber is 1 millimeter wide, just to give you a perspective on the size of everything down here. 1 millimeter is pretty skinny. All right, other questions?
Next question coming from Charlie, once more on YouTube,
Hi, Charlie.
asking, do you feel like there is a difference in philosophy?
I cannot rotate this fiber.
Do you feel like there is a difference in philosophy of spine surgery approach between neurosurgeons and orthopedic surgeons generally?
I think that's an accurate statement, Charlie. I think, first of all, in America, neurosurgeons are better trained to do spine surgery than orthopedics. All right, that's in general. About 90% of neurosurgeons are better than 10%. There's 10% of orthopedics that are probably better than 90% of the neurosurgeons. But for the most part, neurosurgeons are very good at spine. The reason for that is most of the university hospitals where we're trained, the spine is done by neurosurgery. That's controlled by neurosurgery. There are a few exceptions. The reason for that is quite interesting, and it has to do with why is spine surgery done. The answer is spine surgery, for the most part, is done for decompression. Decompression means to get the pressure off something. What are you decompressing? You're decompressing the nerves and the spinal cord. So if you're decompressing the nerves of the spinal cord, you're a neurosurgeon. That's what neurosurgeons do. We operate on getting pressure off nerves and spinal cord. Orthopedic surgeons are not really decompressors of nerves and spinal cord. That's outside their fields. That's why most spine is done by neurosurgeons, because the indications for surgery are decompression of nerves and spinal cord. And orthopedics don't do that. Now, some orthopedics are aggressive and they've adopted the skills to decompress nerves and spinal cord. But for the most part, it's a neurosurgical type problem. Just like neurosurgeons don't do knee replacements, joint replacements, orthopedics don't do decompressions. And the most common, he's moving, the most common reason to do spine surgery is decompression, okay? Whether it's cervical or lumbar or thoracic. Therefore, neurosurgeons control spine surgery in America. As far as, is there a difference in philosophies? Yes, because of the training is different. Orthopedics do spine surgery to do what's called stabilization and reconstruction. So what is reconstruction? Reconstruction is where you reconstruct the spine to make biomechanical improvements. Whether you're taking a tumor out and then you're reconstructing the bones because you're missing bones because you took them out with the tumor ate through the bones. So orthopedics in spine are trained to do reconstruction, realignment, and then stabilization. Neurosurgeons, though, because they don't like giving up part of the surgery to the orthopedics, they just learned how to do reconstruction and stabilization. So neurosurgeons do decompression, reconstruction, and stabilization. Orthopedics just do reconstruction and stabilization. But some of the orthopedics have figured out by training with neurosurgeons, they're given that opportunity to do decompressions, okay? But for the most part, that's why you see mostly neurosurgeons doing spine surgery, because they are trained to do all parts of spine surgery. Whereas orthopedics are not trained to do decompression, and that's the most common reason to do spine surgery. Now, all of that is the old teachings, okay? But now, with the understanding of the disc as the center of focus for pain, I have changed the entire field of neurosurgery. And instead of decompression, reconstruction, and stabilization, I have included a whole new treatment, which is debridement of the annulus. And I pioneered this technique, and it is now the fourth and the most important part of spine surgery, in my opinion. Of course, decompressing the spinal cord is important if somebody's going paralyzed. But the most common problem in spine is not decompression, it's not stabilization with fusion or instrumentation, and it's not realignment. It's actually getting rid of pain from the back of the disc, which is what I do, and I pioneered this treatment. So that is a change in philosophy that 99% of spine surgeons don't even know about. They are totally unaware of this. That's why they don't understand laser. They laugh about it because they have no clue what we're actually doing. And I can understand why they would laugh out of ignorance and stupidity and selfishness. But that's the basis of their laughter, is their own ignorance, stupidity, and selfishness. And I'll be honest with you, when I finished my training in neurosurgery, I was a superior spine surgeon to probably 99% of spine surgeons in the world with fusions, reconstructions, and decompressions. And I did those for many, many years. I've even published peer-reviewed literature on my techniques in fusion. Okay, and I used to laugh at laser surgery too. That was before I actually invented this procedure, and then I realized that there is merit to this technique. So it's been an interesting journey, but I understand why these surgeons feel this way, because they're not taught how to do this surgery. They have no clue this surgery exists. They don't understand it. They've never done it. They've never seen it. So of course they're going to laugh about it. They're laughing because what they're really laughing about is, how could there be an important surgery out there that works that I don't know about? And what they're really laughing at is their lack of training. And they're really saying, holy shit, could my training have been so bad that I don't know about this technique that exists that actually works, that nobody trained me to do? And the answer is yes, you were never trained to do it because your attendings who trained you don't know how to do this surgery. Okay, so how could they train you to do it if they don't know how to do it? You're only as good, your training is only as good as the people training you. And if you're at an institution where there is no laser spine surgery, which is 99% of the time, then how are you going to know anything about laser spine surgery? You're not. And you're just going to assume that it's not good. It doesn't work. It's just a joke because you were never taught to do it. But you were never taught to do it because you were not taught by the best. You were taught by the second, third, fourth, fifth, 10th, 100th best. And therefore, you will always be shitty, in my opinion. We're done. Any other questions?
Yes, we have a question coming from Michael once more on YouTube.
Hi,
Ask-
Michael.
Asking, do you always go through the backside of the disc into the neural foramen?
Yes, we always go through the back when it comes to lumbar thoracic, and we go through the front when it comes to cervical. Next.
Lastly, coming from Lanu once more on
Gotta get rid
YouTube.
of these.
Asking,
Okay.
the medical community
worth it.
refused to acknowledge your treatment while preferring doctors' treatment. How do you overcome this kind of discrimination?
Again, that's a great question, Lanu, along with the same question we had earlier. I am here for patients, to make my patients well. I am not here for the other doctors, okay? I've gone to the meetings. I've been invited to speak. I've spoke on the laser surgery for years and years and years to the best meetings in the world. And they're always very interested, at least on the surface at the end of my talks. And they're like, wow, this is incredible. But they don't incorporate it into their practice. They don't learn how to do the treatment because I'm the only one that can teach them and they don't call me. So they just keep doing what the insurance companies pay for, which is fusions and laminectomies. They want to do just what everybody else is doing, okay? So for me, I don't want to do those treatments because they don't work. You see this scar here? That's a laminectomy. There's another scar for another laminectomy. This guy had the laminectomy. It didn't work. It doesn't work. It doesn't fix back pain. So here he is now having the right surgery, but he's been in pain for 25 years. Nobody should have to suffer like that. His pain will be gone today. All right, let's end the broadcast, and we'll be back in just a moment. We're going to do the facet joint treatment because he has painful facets.